Very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session, Drug-Induced Kidney Disease by Dr. Kamal Goplani, sir. I'm thankful to the participants from all over the country who have taken out their valuable time and are attending this evening talk. Pharm D Community has been created with the sole purpose for pursuing interest, facilitate, and foster awareness and education in the chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my core committee members. Thanks to Pooja, Vaishnavi, Yamini, and Kuldeep. It's my pleasure to release the flyer of our next webinar. The registration of the same will be posted in the chat box, both on both the chat boxes, that is Zoom and YouTube. I'm thankful to our speaker for today, Dr. Kamal Goplani, sir, who is one of India's eminent nephrologist and transplant physician. I'll hand over the session to my teammate Vaishnavi to introduce our speaker for today evening. Over to you, Vaishnavi.
Thank you, Aishwarya. Before that, I would like to welcome all our attendees for this webinar. Today, on the occasion of Teachers' Day, we remember the great educationalist, Dr. Sarvapalli Radhakrishnan, the first Vice President and second President of Republic of India, for his life and work. We pay him our respectful tribute. It is said, teachers gave the gift of knowledge, and here we all present to receive it from Dr. Kamal Goplani, sir. A very happy Teachers' Day to you, sir, and
Thank
also
you.
to all the attendees. To proceed with the introduction, I feel it a privilege for me to introduce our eminent speaker, Dr. Kamal Goplani, sir. Sir has perceived his MBBS, MD, DM in nephrology from MP Shah College, Jamnagar in 1999. He was assistant professor in BJ Medical College for 3 years. Dr. Kamal Goplani, sir, has done his training in nephrology and transplantation from Institute of Kidney Disease and Research Center, ITS Civil Hospital, Ahmedabad. He was also assistant professor in IKDRC, ITS, for 4 years, where he gained experience of managing more than 1,000 renal transplant patients. Sir has been awarded a clinical fellowship in nephrology from University of Ottawa, Canada in renal replacement therapy in critically ill patients. Sir is currently working as a consultant nephrologist and transplant physician at Shalby Hospitals, Ahmedabad. Sir has experience of 14 years. With this brief profile, on behalf of Pharm D Community, I take opportunity to welcome our speaker, Dr. Kamal Goplani, sir, for today's session. Over to you, sir.
A very good evening to all of you, and thank you very much for the kind words of introduction. And today I am very happy about because today is a Teachers' Day, and I am delivering this topic on drug-induced kidney diseases. So we would just start with like drug-induced kidney problems and the principles of drug prescription in chronic kidney disease and acute kidney injury. So I think we will take a case-based approach where probably we would start with the first case, a 67-year-old man with history of diabetes type 2, hypertension, coronary artery disease, congestive heart failure, and chronic kidney disease 3B, a GFR of around 40 ml per minute. He has severe osteoarthritis of hands and knee, and due to which he has been started on naproxen 500 milligram twice a day. after feeling acetaminophen for his joint pain. His medications include furosemide, lisinopril, aspirin, carvedilol, insulin, multivitamins, and cholecalciferol. He develops worsening of hypertension, lower limb edema, increased shortness of breath, and white blood tests show an acute increase in serum creatinine uh, from 2.3 to 5.1 milligram per deciliter, which is consistent with acute kidney injury. Sodium is 125, potassium is 6.1. His X-ray chest reveals mild interstitial lung edema. So, moving, which is would be the direct adverse renal effects of naproxen. So, acute kidney injury, A, B is hyperkalemia, C is hyponatremia, D is worsening of hypertension, E is hypervolemia, and F is all of the above.
Excuse me, sir. This
So
is
I
Miss
think we would be just doing the polls, no?
Yes, sir. Shall I release the poll?
Yeah, please. Or probably at the end, probably what we can do is at the end of the case one, where I would just say the answer at that time, we can reveal the poll. It doesn't matter.
Sir, like if, however it's convenient for you, like I can release it right now also.
Okay.
So I'll launch it, no, sir, then. The poll has been released. I request all the participants to answer as soon as possible. We'll be keeping it on for 30 seconds. It is an anonymous poll, so kindly respond to it without having any fear. Last 10 seconds. So the results of the poll are being displayed on the screen.
Yeah. So I think, yes, I'm very happy. This August audience is very much into the side effects of naproxen. So let us see what does NSAIDs do. Yes, we will go ahead with the, and I will give the answer at the end of the discussion. Okay. So, yeah. Moving further, so we all know that drugs can contribute to nephrotoxicity. Around 20% of acute kidney injuries related to hospital admissions, and around 8 to 60% of hospitalized AKI are because of drugs. Around 19 to 25% of ICU related AKI are because of drugs. So AKIs, acute kidney injuries, are because of drugs. So you see around 20%. So 20% of the acute kidney injuries are because of drugs. Now, why is the kidney vulnerable to the drugs or the nephrotoxins? So if you look into that, there are like patient specific factors, kidney specific factors, and drug specific factors. So looking at the patient specific factors, so like if you see here, most important is true or effective intravascular volume depletion. So like prerenal azotemia, sluggish urinary flow, that can precipitate drug-induced kidney injuries. Then most second important is allergic response to certain medications. Third is probably altered pharmacogenetics, where probably renal transporters can either lose or gain their functions. Then other is like elderly people, female sex, previously existing chronic kidney disease or cirrhosis of liver or nephrotic syndrome, they are all vulnerable to drug side effects. Now, if we look at the kidney specific factors, so why the kidneys are vulnerable? Why? Because high drug delivery, the renal blood flow is around 20 to 25% of the cardiac output. So say if the cardiac output per minute is say 5 liters, around 20 to 25% of that per minute goes to the kidneys. So they handle a very large load of cardiac output. high metabolic rates and workloads. Then renal biotransformation of drugs, increased toxic metabolites and reactive intermediates. Then increase local drug concentration into the interstitium of the kidneys and cellular uptake of the toxins. So this all are the factors, the kidney specific factors which lead to drug nephrotoxicity. Now, if you look at the drug specific factors, now what is important? Important is the duration of treatment, the route of administration, oral versus intravenous, immune effects, formation of heptanes, molecular mimicry, and antibody formation because of the drugs. Then most important here is into this bar when you see the combination of nephrotoxins, non-steroidal anti-inflammatory drugs, contrast agents, ACE inhibitors, aminoglycosides, and cisplatin. If all these agents are given together, probably they can worsen the nephrotoxicity. We commonly see that a patient who like has a chest pain, he is a diabetic patient, he is on oral hypoglycemic agents, he is on ACE inhibitor ARB for blood pressure and diuretics. Now we have to do an angiogram. So if we go for an angiogram, now this contrast will add on the nephrotoxic agents like ACE inhibitor and diuretic, which is already on. So this combination has a high risk for developing contrast associated nephropathy. Then other thing is insoluble formation of crystals in the urine. When we go further, we will just discuss about different drugs which can form crystals. Then increased concentration of toxins within the cells and direct nephrotoxicity of drugs. So if you see certain drugs like aminoglycosides, tenofovir, they are directly nephrotoxic. So when we say about direct nephrotoxicity, I would say that certain viruses also, like we are facing, like the COVID-19, it is directly tubulotoxic. So it causes proximal tubular cell injury. Now, if you look here, we can see the glomerulus. The glomerulus, the structure of the glomerulus, and you can see the proximal convoluted tubule, the tubules, the loop of Henle, the thick ascending limb, the distal convoluted tubules, the collecting tubules, and this all I am showing you why, because when you see the drugs, we will go further and you can see here. See here the efferent arteriole, the glomerulus, the efferent arteriole, the drugs which are bound to the proteins, you can see here. They are not filtered directly. The drugs which are not protein bound, they are filtered directly, and which are protein bound, they by the help of organic anions and organic cations, they are transported into the proximal tubules. So this is how the drugs are excreted which are protein bound. And you can see some portion of the drugs which are filtered, probably they can be reabsorbed back from the peritubular capillaries. And the drugs which are lipophilic, they have the tendency to get reabsorbed from the peritubular capillaries. Now, going further, the most important thing, what are the forms of drug-induced kidney injuries? So if you see the different categories, you have acute kidney injury, where you can have injury like pre-renal acute kidney injury, where the blood flow to the kidneys is decreased. So here you can see the classical example of pre-renal AKI is, if you see, give contrast to the patient, it can cause injury like pre-renal AKI. Then intrinsic. So intrinsic is acute tubular necrosis, the most common cause, and second is acute interstitial nephritis. These are the two most common cause of intrinsic acute kidney injury. And the post-renal obstruction. So it can be because of, say, crystals or cast formation into the tubules. Then second important common cause of drug-induced kidney injury is nephrotic syndrome or proteinuria, loss of protein in the urine. Then third important is tubulopathies. So electrolyte disturbances, either proximal or distal tubular injury, which can lead to electrolyte imbalance, acid-base imbalance. Then formation of stones, hypertension, and sometimes chronic kidney disease. So this all is the spectrum of drug-induced kidney disease. Now, as we had discussed the case, like about the non-steroidal anti-inflammatory drugs. So like naproxen, we have either diclofenac or ibuprofen or itracoxib. They all act on the arachidonic acid pathway. They are COX-2 inhibitors and they decrease the prostaglandin levels. So the prostaglandin levels reduction will lead to sodium retention, peripheral edema. It exaggerates hypertension and heart failure. It can lead to hyperkalemia by type 4 renal tubular acidosis, and it can lead to acute kidney injury by pre-renal AKI and ischemic acute tubular necrosis. The pre-renal AKI, why? Because when the prostaglandins are inhibited, the efferent arterioles they get constricted, and the blood flow to the glomerulus or the interglomerular pressure falls down. Now, if you look at the causes of ischemic acute kidney injury, it can be because of, say, non-steroidal anti-inflammatory agents. It can be calcineurin inhibitors like cyclosporine and tacrolimus, which we commonly use in the post-transplant settings. Angiotensin receptor antagonist and angiotensin receptor blockers, diuretics, and interleukin-2 blockers. So, and exenatide. So, exenatide is once again anti-diabetic drug. So these all are the examples of ischemic acute kidney injury. Now, if we look at NSAIDs, associated kidney effects, what they can do? They can cause kidney inflammation by acute interstitial nephritis, protein leak from the kidneys by nephrotic syndrome. So this first slide shows there are so many cells into the interstitium, lymphocytes into the interstitium, which shows acute interstitial nephritis. Then second is showing the protein leak, the membranous nephropathy formation into the glomerulus. And the last thing which they can do is formation of analgesic nephropathy, where you can see here the kidneys in the C ring shaped form, and it can lead to kidney cancer on long term. And the common effect is papillary necrosis, what you can see the necrosis of the papilla of the kidney. Now, who are the patients who are at risk of developing kidney problems because of NSAID? See, all of us, you and me, they take NSAIDs for short duration because of say headache, backache, or joint pain anytime. But we all don't end up into kidney failure. So who are at risk of developing kidney failure? They are the people who are having volume depletion because of say diarrhea, vomiting, because of diuretics, or effective volume depletion because of heart failure, cirrhosis, or nephrotic syndrome. Or they are hypertensive patients, so treated with antihypertensive medications. So as in our case, it was like the patient is on lisinopril, so it's an ACE inhibitor. So ACE inhibitor, they cause efferent arteriolar dilatation, and NSAID, they cause efferent arteriolar vasoconstriction. And this leads to drop in the intraglomerular pressure. This leads to precipitation of acute kidney injury. And people who are already having some kidney problem in form of chronic kidney disease, and if they take NSAID, their risk of developing acute or chronic kidney disease is higher. Now, which agent is safe? So if you ask me, like say naproxen versus ibuprofen versus diclofenac. So all agents I would say are similarly nephrotoxic, but the shorter acting agents like ibuprofen, say if you want to take, probably you can take them for shorter courses because their nephrotoxicity would be less. And are COX-2 inhibitors safe? No. So the etirocoxib and all coxibs are, like, from the renal point of view, they have the same nephrotoxicity. Now, is the oral agent less nephrotoxic than parenteral? No. So the answer to our question, as many of you had correctly answered, is all of the above. So NSAIDs, when in combination with diuretics and ACE inhibitors, NSAIDs in combination with ACE inhibitor and diuretics, they can lead to acute kidney injury, hyperkalemia, hyponatremia, worsening of hypertension, hypervolemia. So all can be done by the NSAIDs. Now moving further to case 2. So he's a 48-year-old male. He's diabetic for 3 years, hypertension for 5 years. He has hepatitis B virus infection, and he's on tenofovir. And he underwent cholecystectomy. Post-operative course was smooth. He received amikacin for 10 days for wound isolates, which showed E. coli, multi-drug resistant. Patient was asymptomatic, passing 3 to 4 liters of urine. Ultrasound, kidneys, liver, few periodic lymph nodes, and urine routine was normal. Liver function test is normal. As cholecystectomy specimen showed suspicion of malignancy, plan was for CT abdomen. Now creatinine was repeated. Creatinine is 4 milligram. Previously it was 0.8 preoperatively. So What is the cause for rise in creatinine? Is it amikacin-induced nephrotoxicity? Is it just a laboratory artifact? Or do you think the patient has gone into sepsis, which has led to acute kidney injury? Or it is because of the tenofovir, which patient is taking for hepatitis B virus infection? So I would like to have a poll there. Yes, Aishwarya, please. Yes.
Last 10 seconds for the poll.
Yes. So once again, majority of you have given as amikacin-induced nephrotoxicity around 70%, and 20% say it is because of tenofovir, and 10 to 15% believe it is because of post-operative sepsis. So I think the hint here, which we all should see, is the normal urine output. So urine output is around 3 to 4 liters of per day. So let us see going further. So acute tubular injury or acute tubular necrosis, if you look at, can be caused by aminoglycosides, tenofovir, polymyxin B. If you look here, the tubules, the cells, they are all atrophied. And polymyxin B, vancomycin, amphotericin B, chemotherapeutic agents and even radiocontrast agents. Now, if you look at the aminoglycosides, they are antimicrobial agents that inhibit the bacterial cell wall synthesis and protein synthesis, and they are polyvalent cationic molecules distributed in the extracellular fluid, excreted by the kidneys, fully filtered at the glomerulus. At the proximal convoluted tubule, aminoglycosides are reabsorbed via endocytosis. They form a Magellan-Kubelin low affinity high capacity receptors and enter the cells incorporated into the lysosomes. And if you look at here, the incidence of aminoglycoside induced acute tubular necrosis is around 10 to 30%. Usually they have non-oliguric acute kidney injury and usually rises 7 to 10 days after the therapy and can reach baseline by 21 days. The main mechanism is mitochondrial damage. And the risk factors are like prolonged drug exposure and the increased frequency of therapy and underlying kidney disease and other nephrotoxin agents. They can even present as Bartter-like syndrome, where you have metabolic alkalosis and potassium and magnesium and calcium wasting, or Fanconi syndrome, where you have metabolic acidosis and sodium wasting. Now, this is once again a diagram which shows renal tubular cells. Here you have the filtered aminoglycosides from the apical side, and here is the basolateral side. Basolateral side is towards the blood vessel, apical side is towards the tubule inside, and here you can see the aminoglycosides. They are absorbed here and into the cell lysosome enzymes with aminoglycosides, and they damage the mitochondria. So mitochondrial damage is the main mechanism by which aminoglycosides damage the tubules of the kidney, proximal tubule cells. You can see here similarly gentamicin, like it is filtration filtered proximal into the proximal tubular cells, binding into the proximal tubular cells. If you see here, adsorptive pinocytosis occurs, lysosomal trapping, and you can see here like normal kidney tubular cells. 4 days after gentamicin, you can see the deposits of the gentamicin into the peritubular cells. Okay. Now this is once again lysosomal perturbation induced by gentamicin on electron microscopy. You can see here the deposits lamellar. Now this is very important. Why? Because if you give for aminoglycoside certain medications, where if you give one injection in the white 3 injections a day, green, and a continuous infusion, pink. So if you see here, if you give a continuous infusion, the renal cortical accumulation of gentamicin is quite high. And if you give a single injection, probably the renal cortical concentration is quite low. So it is better to give in a single dose aminoglycosides than rather giving 3 times a day or a continuous infusion. Now, as some of you were pointing out towards tenofovir. So tenofovir once again it's an oral antiviral agent that is used to treat HIV and hepatitis B infection. Tenofovir is excreted by the kidneys, filtered at the glomerulus and secreted by the proximal convoluted tubules. So tenofovir is transported into the PTC by organic anion transporters and transported by the carrier proteins. Efflux into the urine occurs primarily by the MRP transporters. So this is the very beautiful pictorial which shows like the tenofovir, if you see here, like through the blood vessel, as you can see here, which we had shown in the starting. So this is number 1. Here the tenofovir organic anion transporters goes into the cells, tenofovir, then MRP receptors and efflux into the urine. So this is the urine side. Okay. Now what happens? What happens is this MRP receptors binding to tenofovir decreases. This MRP and the tenofovir gets accumulated into the proximal tubular cells and it goes into the mitochondria and it causes damage here. So these efflux transporters, when they are mutated, then there occurs the tenofovir toxicity. This is how tenofovir causes proximal tubular cell damage. Now the clinical presentations can vary from mild to severe AKI and acute tubular injury or acute tubular necrosis seen on kidney biopsy, swollen and distorted mitochondria, once again with tenofovir. Proximal tubulopathy, enzymuria alone can occur. Type 2 renal tubular acidosis, phosphate wasting and Fanconi syndrome can also occur. You can sometimes have diabetes insipidus with tenofovir. So case 2 answer, as you were correct, is amikacin nephrotoxicity because it is characterized by an urine output which is normal. So it is non-oligouric AKI is the characteristics of aminoglycoside. So if it was because of sepsis, some few of you were trying to point out to sepsis, but usually the sepsis induced AKI is oligouric AKI. Now moving further, our case 3 once again is a 35-year-old male admitted with severe sepsis and septic shock due to right middle lobe pneumonia. So now the sepsis comes here. Huh? All of you wanted to have some discussion on sepsis. He is having multi-organ failure. Creatinine is 4.5 and uric. Now he is on intermittent hemodialysis. Things get worse. Sputum isolated Klebsiella pneumonia, which is sensitive to colistin only. So which of the following statement is true regarding the dosing of colistin in critically ill patients? Do not use colistin as it is nephrotoxic. Yes, I would agree to that. Load with 9 MIU colistin before starting the maintenance therapy. Start with 3 MIU twice a day directly, or give colistin just before the dialysis to reduce the nephrotoxicity. So I think Aishwarya, we would like to have a poll here that what do you think about colistin in renal failure? So in acute renal failure, what do you think about colistin? Yes. So we are having the poll. Yes. So in this, probably majority of you have answered around 55% that give colistin just before the dialysis to reduce the nephrotoxicity. Okay, and few of you say around 20% believe like me that we should not use colistin as it is nephrotoxic. I agree with all of you, but When it is a multi-drug resistant organism, sensitivity is only colistin, we have to give colistin. Okay, so let's see about colistin. Now, polymyxin B and colistin are antimicrobial agents that are effectively against gram-negative pathogens. They are cationic polypeptide antibiotics given as IV product, converted into circulation into active metabolites, excreted by the kidneys. Polymyxin B is reabsorbed into the proximal colonnade tubules via cellular transport. Now, if you see here, I have highlighted this. So, cumulative dose is very important. So, if you give a higher dose, probably patients develop more nephrotoxicity with 6 grams compared to 4 grams. And other is duration of treatment, 19 days duration versus 13-day duration. So, these two are very, very important for developing acute kidney injury due to polymyxins. Now, switching the gears. Principles of drug dosing in kidney injury, acute kidney injury. So determine the kidney function, which is the equation. Cockcroft-Gold equation is what we usually see. You can click on Cockcroft-Gold and you have the equations there on the internet, and you can calculate, or you have the formulas. Dose adjustment is critical below 30 ml of GFR, and rapidly deteriorating AKI or anuric, consider GFR less than 10. Readjust the dose when kidney function is improving. This is very, very important. Otherwise, you will underdose it. And drug loss in dialysis. As you were rightly saying that probably it has to be given before dialysis. I don't agree with that. And therapeutic drug level monitoring. That is the answer. Like drugs like vancomycin, they are best monitored therapeutically. Okay, so you just monitor the dose of vancomycin. Now, dose adjustment methods. Either you give a loading dose to achieve the rapid therapeutic concentration, then other is the maintenance dose. What you have to see is renal and non-renal excretions. You have two methods, the same dose and prolonged interval, peak dependent action of drugs like amikacin. You give 1 gram every 48 hours, or dose method, small dose at usual intervals. So in that, I would give an example of piperacillin and tazobactam, where usually you give a continuous infusion, say over 24 hours, or you give over 4 to 8 hours, and that works very nicely. Or either you can go for a combination, so small dose at distant intervals. Now, drug loss in dialysis. This is very important. Why? Because hemodialysis, intermittent hemodialysis, what we commonly do using a low flux dialyzers, usually you can remove the drugs which are less than 500 Daltons. If you do SLED, which is slow, low efficiency dialysis, say for 8 hours or 12 hours, where we use high flux dialyzers, where you can remove the molecules from 500 to 1500 Daltons. And continuous renal replacement therapy, where the principle is diffusion plus conviction, where we use high flux dialyzers, we can remove the molecules till 5000 Daltons. And peritoneal dialysis, once again, the effectiveness is less, and you can remove the molecules less than 500 Daltons. And top up dosing following dialysis. So the answer is not what you selected. Why? Because we need to increase the dose or give some more dose of the drug after dialysis. Why? Because depending on the type of dialysis, the drugs will be washed out. So we want the concentration of the drug in the patient, effective concentration, to kill the bacteria. So now this is very important here. If you look at the colistin dosing, if the GFR is more than 60, the loading dose is 9 MIU, and you give 4.5 MIU BD or 3 MIU 8 hourly maintenance dose. And if you see here our patient, intermittent hemodialysis, so you have to load with 9 MIU same. Very important. Loading dose is the same because you want to achieve the therapeutic drug concentration early. And you give maintenance dose, that is only 1 MIU twice a day, 1 MIU twice a day. And you give 1 MIU post dialysis. So you do not give pre-dialysis. If you give pre-dialysis, the drug will be removed in the dialysis. So you give 1 MIU post dialysis to maintain the therapeutic drug level. And if you are doing slow, low efficiency dialysis, you have to give 3 MIU twice a day and CRRT 4.5 MIU twice a day, like the normal renal function. Why? Because it can effectively remove the drug. So the answer to our question is loading dose with 9 MIU before starting maintenance for all patients if they are having normal renal function or with acute kidney injury. Very important. Now, just as we were discussing something about acute tubular necrosis, something I would like to say about vancomycin. Why vancomycin? It is a glycopeptide antibiotic, inhibits bacterial cell wall synthesis. It is a drug of choice for gram-positive organisms. Like we are discussing polymyxin, colistin for gram-negative, vancomycin is for gram-positive. So it is glycosylated cyclic non-ribosomal peptide distributed in the extracellular volume, time and concentration dependent microbial clearing. So time and concentration, very important. Ideal trough levels are 15 to 20 milligram per deciliter, not metabolite, it is excreted by the kidneys. In PCT, uptake of vancomycin into the cell is unclear till now. If you look at vancomycin, it is associated with acute kidney injury. Incidence varies from 2 to 3% to around 30%. In most studies, AKI incidence is around 10 to 20%. Higher acute kidney injury is noted when you give higher doses of vancomycin or the trough level is above 15 to 20. High risk patients with multiple comorbidities and longer duration of vancomycin treatment are associated with AKI. So vancomycin, what we commonly are using now is usually say for bone and joint infections. Then catheter related bloodstream infections, we have a temporary dialysis catheter or a permanent dialysis catheter where we commonly use vancomycin, and other is infective endocarditis. So it is a treatment of choice for infective endocarditis. If you look at vancomycin and renal drug dosing, so GFR is normal more than 60, no dose adjustment. But if the patient is on, say, hemodialysis, then you have to give 0.5 to 1 gram every 48 to 96 hours. Very important. And on CRRT, 1 gram every 48 hours. Or usually with normal, there is 1 gram 8 hourly. So this is very, very important. You need to reduce the dose as the kidney function is deteriorating. Now, if you look at a nutshell, so drug-induced acute tubular injury. So which are the drugs? Like tenofovir, aminoglycosides, polymyxin B, we discussed radio contrast agents, vancomycin, amphotericin B, and the chemotherapeutic agents like cisplatin, isophosphamide, and zoledronate. They all are known to cause acute tubular injuries. Now we look at a very common form of acute interstitial nephritis caused by the drugs. The commonly used drugs which lead to acute interstitial nephritis are like NSAIDs, antibiotics like cephalosporin group of antibiotics, rifampicin. These are the drugs which commonly lead to acute interstitial nephritis. So how does the patient present here? Usually it is a non-oligouric. Once again, very important. The urine output is maintained. The creatinine is raised. There is a skin rash, bulky kidneys on ultrasound, and eosinophils in the urine. So usually the people present with fever, rash, and eosinophilia. Eosinophilia on the peripheral blood smear. So these are the very common presentations. Here in this slide, you can see the tubules, proximal convoluted tubules, and you can see the epithelium. Very nice. And here you can see so many lymphocytes which are there into the interstitium and the tubules. Interstitial infiltration of the lymphocytes. So this is very, very, very important. You can see interstitial many plasma cells which are surrounding the tubules. So acute interstitial nephritis is very important. Why? Because you should have a very, very important level of suspicion. And when you stop the drugs, usually the patient recovers by itself. And if the creatinine is high, about 2.5 milligram, then usually a short course of steroids, around 6-week course of steroid is useful in recovering from acute interstitial nephritis. Now, moving further, drug-induced osmotic nephropathy. So which are the drugs which can lead to osmotic kidney damage, like intravenous immunoglobulins, which are the drugs which are commonly used for Guillain-Barré syndrome or probably which are commonly used, and hydroxyethyl starch, which was commonly used previously in the ICUs for volume resuscitation. So it's a colloid which is used for volume resuscitation. But now usually what we use is albumin. We don't use hydroxyethyl starch in the ICUs, and dextran, similar, and radio contrast agents and mannitol. So mannitol is the drugs which is commonly used for reducing the cerebral edema. So intracranial pressure is reduced by mannitol, but this is the drugs which can lead to osmotic nephropathy. So you should always check for that. Now moving further, other form of drug-induced kidney disease, the crystal nephropathy. So if you see here, drugs like indinavir, acyclovir, sulfadiazine, this all, and ciprofloxacin, these all drugs are known to cause crystal nephropathy. In this, if you see here, the sulfadiazine, the longer acting sulfa, which can lead to birefringent shock of bead-like crystals or shells. So this is very, very characteristics of sulfadiazine crystals, which you can see in the phase contrast microscope. And this is indinavir. So indinavir is a drug where you find needle-shaped crystals. So needle-shaped crystal, and where you can see either in the rosette formation, forming the rosettes because of the needles. So this is classic of indinavir sulfate crystals. Now moving further, a 24-year-old gym trainer without previous history. So he is a very good fit person. History presented with edema feet, new onset hypertension. On investigation, creatinine is 2.5, elevated. Albumin is low, 2.5. Cholesterol is high, 450. He denies taking non-steroidal anti-inflammatory drugs, but he confessed that for bodybuilding, he used to receive anabolic androgenic steroids and protein supplements for bodybuilding. Renal biopsy showed focal segmental glomerulosclerosis. So what is your take on it? Is the anabolic steroids which have done this, or they are not nephrotoxic? Protein supplements are nephrotoxic. Kidney problem is due to exercise related rhabdomyolysis. Is very important. Why? Because we have a very, very famous example of like the professors today, as I am discussing this. Why? Because the professors of Harvard, once they all decided to go for a marathon race for raising fundraising maneuver, and what at the end they landed up with rhabdomyolysis and acute kidney injury, many of them. So when you go for unaccustomed exercise or training, it leads to muscle injury. Then other is important, like medications like statins, you all know, like cholesterol lowering drugs which we commonly give, like atorvastatin, rosuvastatin. They are all known to cause rhabdomyolysis. We had a very recently a case where patient had acute coronary syndrome. He was given ticagrelor and he was given rosuvastatin. Now the combination of these two led to rhabdomyolysis and acute kidney injury. We had to dialyze the female for around 6 to 7 times, after which the urine output started. We just omitted the ticagrelor and rosuvastatin and her kidney function improved. She had CPKs of the level of 1 lakh. So I would like to request Aishwarya to take the poll here for this question.
Yes, sir, I have launched the poll. Polling will be on move for 10 seconds, so please do submit your response as soon as possible. Last 5 seconds.
Yes,
So
so
I
now
hope
the
you
results
the
are
results.
out, and the maximum number of people say proteins are nephrotoxic. So you are right, but as we discuss, you will know what is the answer here. Why? Because in a normal renal function, people with normal renal function, you can take normal protein diet, that is not a problem. But with impaired renal function, chronic kidney disease, we need to decrease the amount of protein intake. Yes, you are right. Few of you have said that anabolic steroids are not nephrotoxic, so they are wrong. And few of you have said around like rhabdomyolysis was the cause. So I was discussing about rhabdomyolysis. I agree. But here it is not the case. Why? Because he is a gym trainer. See, he is a regular fit freak. So he is regular into exercise. So it is not new for him. It is not new for him. And the biopsy is showing FSGS. This is very important clue against rhabdomyolysis. Why? Because that will show a cast nephropathy. Rhabdomyolysis will give a cast nephropathy. This is focal segmental glomerulosclerosis, a form of glomerulonephritis. Let us see. Yes. So what are the drugs which lead to glomerular lesions like minimal change lesions? It is because of non-steroidal anti-inflammatory agents and interferon, which we use for hepatitis B and C infection. Then lupus like nephritis can be caused by quinidine, methyl dopa, hydralazine and procainamide. The methyl dopa and hydralazine are the antihypertensives which we use in pregnancy. And quinidine and procainamide are used as anti-arrhythmogenic drugs. Membranous glomerulonephritis is caused by NSAIDs, gold and penicillamine and captopril. These are the agents which can cause membranous glomerulonephritis with proteinuria and nephrotic syndrome. Very important, previously gold was used for treatment in Ayurvedas and this has led to membranous nephropathy in many patients. Focal segmental glomerulosclerosis. This can be caused by interferon, lithium, palmitronate, androgenic anabolic steroids, and heroin. Heroin is a prototype drug which is known to cause FSGS. Very, very important. And this you can see here. This biopsy is showing FSGS. So focal and segmental glomerulosclerosis, collapse of the glomerular tuft. So this is the glomerular which is collapsed. Okay. Now, if you look here, the anabolic steroids used for bodybuilders and complications are endocrine effects, hepatotoxicity, hyperlipidemia, neuropsychiatric disturbances. And as we saw here in kidneys, they can lead to focal and segmental glomerulosclerosis. If you look here at the study, the mean creatinine was 3, which got gone up to 10. And nephrotic syndrome was a presentation in 30%, 50% at nephrotic range proteinuria. There was microhematuria in few. And FSGS was the biopsy finding in 9 out of 10. And perihilar sclerosis. Collapsing variety was there in 3. So focal segmental glomerulosclerosis can be either say cellular type or collapsing variant or not otherwise specified. So here what you commonly see is perihilar sclerosis. You can see here. So if you look at the follow-up, out of 10, 1 progressed to end-stage kidney disease, 7 were treated with renin-angiotensin receptor blockade and discontinued anabolic steroids. 1 patient restarted anabolic steroid. Creatinine decreased from 2.3 to 1.6 and the main mechanism was focal segmental glomerulosclerosis, which is post-adaptive. So structural and functional adaptations from hemodynamic glomerular stress, like large body mass index, high protein diet, and hypertension. This lead to post-adaptive FSGS. Or it can be direct nephrotoxicity by androgens, which can lead to glomerular injury. So the answer here is none of the above. Why? Because anabolic steroids, as we say, they are nephrotoxic. Okay. Now, if you look at the this cartoon here, which shows the different sides of the drugs. Like you see here, non-steroidal anti-inflammatory drugs, as we had already discussed, they act on efferent arteriole and they decrease the blood flow to the glomeruli. Then if you see here, as we are discussing, intravenous immunoglobulin, hydroxyethyl starch, they all cause osmotic diuresis and osmotic nephropathy. Then drugs like aminoglycosides, tenofovir, vancomycin, polymyxin, they act on the proximal tubules and they cause acute tubular necrosis. Then if you look here, like drugs like ciprofloxacin, acyclovir and sulfadiazine, they all cause crystal nephropathy, crystal deposition into the collecting duct, and cause acute kidney injury. And drugs like topiramate, which is probably used for epilepsy, atazanavir and sulfadiazine. These all drugs once again can block the collecting systems. And very important, acute interstitial nephritis, where the drugs can act by immune mechanisms on the interstitium and where they can cause acute kidney injury. Now, this is a slide, probably it is not very nicely visible, but I would like to highlight here the herbal remedies. The herbal remedies like the aristolochic acid, which was used in the Chinese herbal medicine, had led to chronic interstitial nephritis and urothelial malignancies. And other important thing is Ayurvedic Indian herbs, which have a high content of lead and arsenic, like we were using for this COVID-19 pandemic. Also, if you use in long duration and larger doses, can lead to interstitial kidney damage, and lead also can lead to interstitial kidney damage. Now, how to prevent drug nephrotoxicities? This is very important. Why? Hydration is the most important thing. Drug dose modification according to the glomerular filtration rate, use of nephroprotective strategies where available. Like if you are giving a contrast agent, if you want to prevent the nephrotoxicity because of contrast, then what you can do is you can use an isoosmolar or a low osmolar contrast like iodihexanol, and you can give intravenous hydration 1 hour before and 6 hours after the contrast. You give IV normal saline, or you give half normal saline with 3 ampule soda bicarb at 1 ml per kg body weight 1 hour before and 6 hours after, and you can give N-acetylcysteine or mucomix. So this all will help to prevent contrast associated kidney injury. So wherever nephroprotective strategies are available, you can use them and probably try to protect the kidneys. And beware of drug-drug interactions. Very, very important. What I am telling here is drug-drug interaction. Why? Because as we saw in case number 1, he is a diabetic, hypertensive, he is on ACE inhibitors. Now you have arthritis, knee pain, and you give him NSAIDs. Now this interaction of NSAIDs and ACE inhibitor will lead to acute kidney injury and hyperkalemia. So in such situations, if you want to give short course of NSAIDs, you should omit ACE inhibitors and you should switch them to calcium channel blockers and give a short course of NSAIDs if it is must. If you do this and then once again switch back to ACE inhibitors after 2 to 4 weeks, and then if you see the chances of AKI are much reduced. So important is drug-drug interaction. Now moving to our 4th case. He is a 68-year-old male admitted with episode of hypoglycemia, history of fall and injury. He had acute gastroenteritis 3 days and that lasted for 1 day. In the past medical history, he has history of diabetes 15 years, hypertension 10 years and chronic kidney disease, creatinine of 1.7. Now creatinine is 2.2, HbA1c is 5.7, CT brain is normal. If you see the drug history, he is on telmisartan, amlodipine, glimepiride 2 mg, metformin 1000 mg. So now what do you think? Which of the factors has contributed to hypoglycemia? Acute gastroenteritis leading to poor oral intake, poor food absorption. So because he is already on glimepiride, or CKD status of the patient, or acute renal failure leading to decreased elimination of glimepiride, or all of the above. So I would request Aishwarya to take the poll. Yes. So most of you are correct. informed that probably all of the above are contributing, and acute renal failure leading to decreased elimination of glimepiride is an important factor here. Yes, I would agree with that. Very good. Now, moving towards the case. So, we have to stop all oral hypoglycemic agents, especially metformin and longer acting OHAs. Shift the patient to insulin, withhold RAS blockade, oral or IV hydration, and monitor urine output in any acute illness in diabetic patients. It's very important. So this is the list of drugs which you will commonly see, which we use for oral hypoglycemic agents for diabetics in chronic kidney disease. So most important here is the green bars, which you can see like the glinides, the ripaglinide and the netaglinide, which we can commonly use in patients with chronic kidney disease till stage 5. Then gliptins, newly available, what you can see here, linagliptin, which you can use even if the patient is on dialysis. For sitagliptin and vildagliptin, you have to reduce the dose if the patient is having stage 4 or stage 5 CKD. Then exenatide, as we were seeing, which we commonly don't use it. And then SGLT2 inhibitors. So these are the drugs which are now the game changers. Now this SGLT2 inhibitors like empagliflozin and dapagliflozin. So these drugs are now reducing the proteinuria. They reduce the progression of chronic kidney disease also. So these are the drugs which will be commonly used now with metformin for patients with diabetic and kidney disease. So if you see here, what are the principles of using diabetic agents in CKD? So glimepiride, longer acting agents probably should be avoided. Metformin can cause lactic acidosis. Pioglitazone leads to fluid retention, and DPP-4 inhibitors are safe. Ripaglinide is safe, and acarbose usually they have GI intolerance. Otherwise, it is. Now we continue the case. So he was treated with dextrose infusion for 48 hours and given tramadol 100 milligram BD for pain because he had injuries. Ceftriaxone 1 gram 12 hourly was started. Oral hypoglycemic agents and telmisartan were stopped. Regained consciousness and became alert after 24 hours. So level of consciousness deteriorated on the third day once again with myoclonus and one episode of seizure. Now at this time the sugar is good, 150 to 200. No episode of hypoglycemia. MRI brain is normal. EG, there is no seizure activity. But the creatinine has jumped from 1.7 to 3.5. So what do you think is the possible cause of this altered mental status, which is now again? So previously it was because of hypoglycemia. Now what do you think? It is neuroglycopenic brain damage because of hypoglycemia, or uremic encephalopathy because the creatinine is increased, doubled up from 1.7 to 3.5, or is it a drug-induced encephalopathy, or is it hospital psychosis because now the patient is into the ICU? I would request the poll here. Yes. Yes. So 40% of you say that it is because of uremic encephalopathy, and around 37% say it is drug-induced encephalopathy. So let us see how the case takes us. So if you look at NSAIDs, they are contraindicated in chronic kidney disease. If you look at opioid analgesics like tramadol, they have tendency to cause seizures, respiratory depression. Morphine leads to CNS depression. Pethidine leads to CNS depression. Codeine CNS depression. So if you see here, the cause was drug-induced encephalopathy because of tramadol. See, uremic encephalopathy will not occur at a creatinine of say 3.5. Usually the urea more than 200s and the creatinine levels which are say around 8 or 10, probably you can see the patients with uremic encephalopathy. So sensorium improved 72 hours after withdrawal of tramadol, and creatine improved to baseline within a week. So this is how we probably have tried to cover the different agents and their implications in kidney disease. Now we cannot end the drugs and the kidney discussion without the current topic of proton pump inhibitors and kidney. As you all know that sometime or the other we have taken this proton pump inhibitors for gastritis or reflux. So pantoprazole, omeprazole and rabeprazole. So are these all agents safe or not? They are known to cause acute interstitial nephritis. This is a paper from our own India, Manipal Hospital, which they have Madras Medical Mission, sorry, and but they have shown acute interstitial nephritis due to proton pump inhibitors. So this where you can see here, because the majority of the people they take pantoprazole, so 84% was pantoprazole, omeprazole 10% and 5% were on rabeprazole. And if you see here the age group 51 to 70 years. Proton pump inhibitors and risk of incident CKD and progression or to end-stage renal disease. So this paper which appeared in Journal of American Society of Nephrology, like which showed that probably people who are taking long-term proton pump inhibitors, they can end up into chronic kidney disease. Now, if you see here the duration of proton pump inhibitors, and if you see here like 1 to 2 years, so this is the duration when the peak problem with proton pump inhibitors appears. So this is very, very important. Cumulative exposure, if around 360 to 700 days, then probably there is a peak problem with proton pump inhibitors. So summarizing, kidneys play an important role in drug metabolism. Drug nephrotoxicity has variety of manifestations and can affect all compartments of the kidney, as we saw, acute tubular necrosis, acute interstitial nephritis, and all form of electrolyte imbalances. Common medicine require dose modification in chronic kidney disease and acute kidney injury. And we should have a friend in need is a friend indeed. We all know, probably, I think I would say here, a nephrologist would be a good friend. Just joking. So books are our best friends. So we should always go through this renal drug handbook whenever you need, which will help you in modifying the dose of all the commonly used medications. And thank you. And I think I would like to open for questions.
Thank you, sir. It was a really informative session. Now we'll move forward to question and answer session. So the first question we have is,
Yes. So if anyone has questions, probably either you can write it down in the chat box and probably Aishwarya can take them further.
hello.
Yes, sir. One of my teammate Yamini will be taking up the question. So Yamini, please proceed with it.
Yes, now we'll move forward with our question and answer session. So the first question we have is, certain cholesterol medications like statin can lead to kidney diseases, but in certain cases they are important to be given. So should we stop that medication, or do we have an option to add another medication with it to prevent that kidney dysfunction? So should I repeat the question?
Aishwarya, do we have any questions?
Sir, am I audible?
No, I think you are not audible, Aishwarya.
Yamini, am I audible to you?
Yes, you're audible. Is my voice clear?
Yeah, your voice is clear, I guess. Sir, can you hear me now? Hello. Yamini, just stay online. I'll just call sir and I'll let him know that he's not audible.
Yeah, sure. By the time, if our participants have any questions, you can post them in the chat box.
Also, the registration link for our upcoming webinar are also posted. The interested attendees can register.
I would request all my participants to be a bit patient. So we'll be joining the meeting again so that there's some technical issue. He's unable to hear us. So kindly wait and your questions will be answered. Thank you. By the time Sir rejoins us, I would request everybody to kindly fill out the registration form and the feedback form, which is posted in the chat box. Sir, am I audible now?
Yeah. You are audible. Yes, very nice. Very nice. Yeah. So I think
Hello.
because of some technical issue, I was not able to listen to
Yes, sir.
Aishwarya, but now I think hopefully we have got connected, and so we would take up some questions. Yes.
Yes, sir. Yamini, can you please read out the questions?
Yeah, sure. So our first question is, certain cholesterol lowering medications like statin can induce kidney diseases, but are also important to be given in that patient. So should we stop that medication, or we have an option of another medication to prevent kidney dysfunction?
Yeah. So as such, the cholesterol lowering agents, they are safe even in acute kidney injury or patients with chronic kidney disease. Even our patients with chronic kidney disease, we use statins commonly, and there is no need to stop them, but sometimes we need to be cautious. Why? Because if the patient, like as I described, if he is having acute kidney injury and he is having muscle pain, and if you see urine myoglobin is high, and at that time if you go for cpk levels and if they are elevated in say thousands, then probably it is rhabdomyolysis induced by statins. We need to stop the statins and hydrate the patient, and usually they recover. So because of some enzyme defects, sometimes statins can lead to rhabdomyolysis. So we should be cautious and knowing them. Otherwise, statins are safe medications and we can definitely take them. No need to stop in any form of kidney dysfunction.
Thank you, sir. The next question is, what are the lifestyle modifications to prevent CKD and how to enhance GFR?
Yeah, so I would also like to enhance my GFR, but I don't think, fortunately, we have such modes. But I would say, yeah, probably you are right. So important is daily exercise. So that is very, very important healthy lifestyle which we can take up. And other important thing is weight loss. So weight loss is also very important for preventing chronic kidney disease. And other thing is avoiding smoking, and other thing is avoiding over the counter painkiller medications. And if you have diabetes or blood pressure, to keep them under control, that is very important. And other important thing is to keep your bodies hydrated. So if you are not having any form of kidney or heart disease, probably around 8 to 12 glass of water or 2 to 3 liters of water is what is needed daily.
Okay. So the third question we have here is, What are the advantages of 3D bioprintable kidney transplant over normal donor kidney transplant?
Yeah, so this is a new thing which is coming up, and probably I would say that it would be the future. So it is not yet started probably in our center, but I think shortly it will be there, and I think we would be, if we are able to match the kidneys, probably their long-term outcome is better than what we are doing at a conventional way now. Definitely.
The next question comes from a participant who says, I came across so many people, especially farmers, who are using NSAIDs for their lifetime to reduce their pain. They definitely suffer from AKI at the age of 40. Can you explain me the alternative way to handle this case?
Yeah, so probably I think like the question here is like if you see like in rheumatoid arthritis, sometimes what you see like we have to give NSAIDs for 3 years, 4 years, and it has been seen that they are safe when they are not combined with other nephrotoxic medications. There was a study which showed around 4 to 4.5 years the NSAIDs were used for patients with rheumatoid arthritis. But now I would say that we should probably be using the disease modifying agents, DMARDs. So now for any form of arthritis, we have disease modifying agents. Probably if we use them and modify our disease inflammation, we would not need NSAIDs. So a short course of NSAID for any illness is okay, but for a prolonged course, I think we should think twice, like what is the cause for that. And if say it's osteoarthritis of the knee, which is troubling us, it is better to get the knee replaced than to take long-term NSAIDs and end up with kidney failure.
Thank you, sir. The next question is, does renal calculi have a tendency of recurrence, and is there any chance of hereditary formation of stones?
Yes, so the answer is yes, the renal calculi can recur and there is chances of running in the families. Why? Because there are some disorders like increased parathyroid hormone, hypercalciuria, familial, where you can have recurrent stone. So important is if you have stone once, probably you should get your metabolic workup in form of calcium, phosphorus, parathyroid hormone levels, bicarbonate, serum, and 24-hour urinary supersaturation test in form of urinary calcium, phosphorus, oxalate, and citrate, so that we can know what is the exact cause for renal stone formation and we can address it. But it can recur definitely.
Okay. So we have a couple of more questions. Can we take that up?
Yeah, sure, please.
Okay. So the next question is, what is rationalized antibiotic usage in renal dysfunction? Can you explain more about it?
Yeah, so rationalize antibiotic usage in renal dysfunction. So what I would say is you should use antibiotic if they are needed. Even if the patient is having chronic kidney disease or acute kidney injury, there is no problem to use any antibiotic. Important is dose modification depending on the creatinine clearance. You take a Cochrane Gold formula, creatinine is 3, get his EGFR, what is the value or the creatinine clearance. Say if it is less than 30, you have to modify the dose of the drug according to that. Very important. Why? Because if the patient is having say sepsis because of any reason, say a pneumonia or a abdominal sepsis or infective endocarditis, he is having creatinine of AKI, creatinine of 2 or 3, we cannot stop antibiotics. So we have to just modify the dose of the antibiotics depending on the creatinine clearance. That is what we have to do, and probably we should avoid nephrotoxic medications together. Like we should avoid, when we are giving an antibiotic which is nephrotoxic, like say colistin or amikacin, we should avoid giving contrast to that patient. We should avoid diuretics. We should avoid ACE inhibitors in that patient. Why? If you give combination of all nephrotoxic medications, that can lead or that can increase the chances of renal dysfunction.
The next question is, what is medication for proteinuria patient whose EGFR is less than 15 ml per minute per 1.73 meter square? Are ARBs going to help for these patients?
Yes, so ARBs are good for proteinuria if the EGFR is low. It is not that ARBs won't help, but most important thing is you have to check for potassium levels. So serum potassium levels have to be kept in mind when you are giving ARBs in low GFR. We do use them. Definitely, they are the drug of choice.
The next question is, can pantoprazole be used in kidney stone patients?
Yeah. So pantoprazole can be used. As I say, we can use the pantoprazole very commonly and easily. But now the thing is going about de-prescribing pantoprazole. If the patients are on long-term pantoprazole as a co-prescription, probably we need to think that what was the reason which has led to the start of pantoprazole, and if they don't have any compelling indication, probably it is important to de-escalate pantoprazole and to put them on probably H2 receptor blocker or to stop them altogether. So why? Because long-term use is associated with interstitial kidney damage. So we need to be aware of that. Short courses or when it is needed, like say erosive gastritis, ulcer disease, esophageal reflux disease, we definitely need to give pantoprazole.
So the next question is, sir, please explain about CRRT.
Yeah, so CRRT is like a continuous renal replacement therapy. It is a form of dialysis for acute kidney injury, where if the patient is hypotensive, even then we can use a CRRT. Like conventional hemodialysis, the patient, if we start acute kidney injury patients, they can end up into hypotension. Or if the patient has low blood pressure because of sepsis, he is on multiple inotropic support. In that condition, CRRT is the best mode of therapy, and the clearance is diffusion and conviction. So you can have middle molecule clearance also. And in septic patients with acute kidney injury, CRRT is the best form of therapy, and especially in patients with increased intracranial pressure and patients who are having hepatorenal syndrome, CRRT is the preferred modality of dialysis in acute settings.
The next question is, how can nanotechnology help in patients with renal impairment?
Yeah, so I'm not aware of that. So probably somebody wants to give it a try. I don't mind.
Okay, sir. The next question is, what is the patient outcome of renal transplant for the patient who is suffering from renal amyloidosis?
Yeah, so renal amyloidosis, we have either AL amyloidosis or AA amyloidosis, and AA amyloidosis is chances of recurrence after transplantation are quite high, and the graft loss is also quite high in the range of say around 40%. So probably renal amyloidosis is a condition which can recur post transplantation and can lead to graft loss.
The next question is, how to manage ATT in CKD patients?
Okay, so anti-tubercular therapy in patients with CKD, you have to alter the dose, and the most important alteration will be for pyrazinamide and ethambutol. So INH, probably you can give 200 milligram in a day in a 60 kg patient, and rifampicin 450 milligram to 600 milligram is okay, but ethambutol needs to be half the dose, and pyrazinamide probably has also to be reduce the dose according to the eGFR. So dose reduction is required, otherwise you can give AKT. There is not a problem with anti-tubercular therapy in CKD patients because they commonly have pleural effusions because of tuberculosis in CKD.
Okay, and here we have our last question for today. Please explain the role of stem cell therapy in CKD.
Yeah, so stem cell therapy, it has role in probably all the diseases. We all know that now it is coming up. Even the COVID patients, they are trying to do stem cell therapy. So still it is a investigational thing. And in patients with chronic kidney disease, like you say, specific patients who have chronic kidney disease because of say SLE or other immunological conditions, probably they usually sometimes benefit from stem cell therapy. But it has role in patients with say myeloma and renal failure, where stem cell therapy definitely has a role, otherwise not.
Okay, thank you, sir. The session was really informative and we appreciate all our participants' doubts being cleared. I further hand over the session to Vaishnavi.
So before that, if you have time, I would just like to ask one question, sir.
Yeah, sure.
So in the PPT, I saw the dosing, the loading dose of colistin was in the range of 9 to 12 MIU. So usually we have seen a loading of 9 MIU. So when do we actually exceed 9 MIU? Like in which kind of patients, or is there some formula for that?
No, usually the loading dose is 9 MIU, but suppose the patient is the weight is very like in US settings where the weight is very much and the volume of distribution is high. At that time, probably you sometimes give a bigger loading dose. Otherwise, usually we give 9 MIU.
Okay, sir. Thank you so much. Vaishnavi, I would request you to proceed with the section.
Excuse me.
Aishwarya?
Before we proceed further, we have one more question from participant. Can we take that up?
Yeah, sure, sure.
The question is, what is the role of hydration in patients with CKD and how does it help?
Hydration in patients of CKD.
Yeah.
Yeah, so if the patient is already having chronic kidney disease, we usually restrict the fluid intake, like 1 to 1.5 liter per day, depending on the urine output. So usually if the urine output is nil, we restrict the fluid intake to 1 liter, but if the urine output is say 500 ml per day, then we allow till 1.5 liter per day. So once the chronic kidney disease has already set in, then there is no role of hydration. Probably it is better to restrict the fluid intake.
Thank you, sir. Here we declare our question and answer session is over. Over to you, Vaishnavi.
Thanks, Yamini. Here we come to the end of our session. I, on behalf of Pharm D Community, thank respected speaker, Dr. Kamal Goplani, sir, who graced us with his presence and enlightened us on the topic. Thank you, sir, for sharing with us your words of wisdom. I thank all the attendees for showing their interest in the webinar. Last but not the least, I thank my organizing committee for all their efforts. Finally, I thank one and all for making this event a success. Thank you.
Thank you very much. And I also enjoyed the session and the question answers were really nice. Thank you.
Yes, sir. I hope all our attendees are satisfied as you answered all of our questions. Thanks a lot, sir.
Thank you. Thank you very much.
Thank you so much, sir, for accepting our invitation and taking out time during such tough times of COVID-19.
Oh, no, no, you are always welcome anytime. Okay.